Cis bleeding is the most frequently seen complication in PLD. It is suspected when an acute onset pain occurs in the upper abdomen or in the flank and can be diagnosed with ultrasound, CT or MRI scan. In these imaging modalities, fibrin wires and blood clots can be seen inside the cyst, though with an ultrasound these can sometimes be hard to distinguish from a biliary cyst adenoma or biliary cyst adenocarcinoma. Differentiation between these three diagnoses can be made with a CT or MRI. Cis bleeding occurs predominantly in larger solitary cysts with a mean size of 11 centimeters. Due to the self-limiting nature of this complication, conservative treatment is usually advised. Hepatic cyst infection is the second most frequent complication in PLD and causes a combination of pain in the upper right abdominal quadrant, malaise and fever. While these symptoms are truly indicative, the diagnosis can be confirmed by aspiration of cyst fluid, biochemical parameters or a PET-CT scan. It is estimated that 1% of all patients with hepatic cysts develop a hepatic cyst infection, and most are thought to arise from bacterial translocation across the intestinal barrier, since E. coli and Klebsiella are most frequently found in blood cultures or cyst aspirates. Treatment of cyst infection is important because if left untreated, hepatic cyst infections can lead to sepsis and ultimately death. Treatment consists of antibiotics based on culture and aspirate results. In case of recurrent cyst infections, an individual approach should be followed. One approach is prophylactic selective decontamination of the digestive tract, also called SDD, which has been proven effective in one study. Alternatively, surgical procedures can be used as a last resort in recurrent cyst infections. Patients often worry about hepatic cysts rupturing into their abdomen. While this is a complication in PLD, it is rare enough to merit publication in case reports. Cyst rupture is associated with an increase in cyst volume that can be caused by cyst hemorrhage, trauma, or spontaneously. Cyst rupture should be considered when severe abdominal pain occurs in a PLD patient. It can be diagnosed when free fluid is visible around the liver in radiological imaging or with an ultrasound. Sometimes a residue of the cyst is still visible. A conservative treatment is warranted if possible, but in hemodynamically unstable patients, treatment is required through either percutaneous drainage of ascites and liver cysts or surgical interventions. The last complications, hepatic venous outflow obstruction, can be seen when strategically placed hepatic cysts grow and compress the inferior vena cava. This very rare complication is most frequently seen in female patients with moderate to severe PLD. Symptoms consist of peripheral edema and ascites, which warrant the need for treatment. However, there is no consensus on the treatment of hepatic venous outflow obstruction currently, so a personalized treatment is recommended. We advise initial management with diuretics followed by long-term solutions such as stenting of the inferior vena cava or volume-reducing treatment. In the following video, we will tell you more about the volume-reducing options in PLD.